The Retina conference day. So Dr. Paul will start. So my case is a 72-year-old man. 1 week before presentation, he felt like he had a scratch on his left eye, and apparently his wife told him she saw a scratch as well. His other visual symptoms included floaters, and also he noted that the left eye was gradually getting worse compared to the right eye, but he didn't see much concern. So some of his medical history: he had high blood pressure, high cholesterol, CKD, and cancer. Surgical treatment for both cancers, either nephrectomy of the left kidney and then prostate removal.
Scott, can you hear?
It's a little quiet, but I'm reading along as well.
I'm just looking how far away everything is. Hold on, let me see if I can move this. Go ahead, keep going. I'm just gonna see if I can center the owl.
And then his systemic meds, pretty normal, metoprolol, amlodipine, Lipitor, aspirin, praloxate. So his eye vitals without correction, the right eye was 20/20. His left eye is 20/100 and can hold just the 20/80. And his IOP was within normal limits via donut. So God, you can hear me.
Okay, this is as good as it's going to get for now. Go ahead, just project. I can unplug it. I don't want to unplug it though. That's gonna. I can't imagine what that's. Yeah, I know. I think that's going to be too much.
Yeah, we can move the. How about that? How about that? Yeah.
All right, Scott. So this is the right eye. If you want to describe what you're seeing.
And then you can follow with the pointer. So as he describes, Sahas will point to things.
Okay, this is a color fundus photo. The media appears clear. Disc margins are flat and sharp. It looks like there is a little bit of pallor to the disc on the temporal side there. Vessels look okay as far as caliber is concerned. Within the macula, my attention is drawn to these hypopigmented, scattered, circular, sharp looking lesions, we'll call them. There's one centered a little bit larger than the others right there within the fovea.
Some of the spots on this image are on the camera. That's an artifact.
Camera, yeah.
But the spots you're talking about are real.
These ones, this one, this one.
And that was my question.
Yeah.
I'm sorry.
Looks like Orion.
This is a 2016
They all
picture. This is
these
from our
models
pre-wide field camera days.
This is the old camera.
Some of these other ones are from the camera. Like these
I
are the
love
ones
that.
It took nice.
These are real.
Those are not my grinder.
Okay, so
You
this
can see them there.
is the other eye.
Same black.
All right. So this is a color fundus photo of the eye that had that decreased visual acuity at presentation. The picture looks similar with the exception that the deposit looks more centrally focused and now it's enlarging. Along with the hypopigmentation, there's more of a yellowish looking color directly central over the fovea there.
Perfect. All right. And then this is a autofluorescence of both eyes. You can do the right eye first real quick and then we'll go.
Sure. So the fundus autofluorescence of the right eye, there is hyper autofluorescence, which is correlating to where those hypopigmented lesions were on the color fundus photo, with a little bit of hypo autofluorescence surrounding each of the hyper areas. And moving over to the left eye, I'm seeing, focusing right centrally, that larger lesion has a hyper autofluorescent border with hypofluorescence surrounding it. And that lesion is actually a little bit less hyperfluorescent than some of the other scattered lesions that were surrounding it.
It's interesting. It's in the center of the macula. Can you think of a reason why there might be a little less hyperautofluorescence there? Just based on its location? Like if you look at the other picture in the center of the macula.
Yeah, it's a little bit thinner there, and it's supposed to be dark.
It's probably the macular pigment blocking some of the autofluorescence. Then do you remember, Scott, the two causes of hyperautofluorescence? There's two.
Drusen and
kind of more broad.
Lipofuscin.
Increased signal. So you've got increased signal, right?
Okay.
And the other one is The other one's the one that's kind of tricky. It took me actually probably 5 years to understand.
I don't
So you
remember.
can get a window defect. So you can actually literally get a window defect in the retina. So the chromophores, which is actually much of the hyperfluorescence you see. So when you see hyperfluorescence, a lot of times it's the absence of outer retina. So it's either increased signal or window defect.
yeah. And so the thing about this is it looks sort of homogeneous and not patchy hyperautofluorescent. So you can describe the right eye OCT.
All right, so we're looking at an OCT of the right eye.
Are you there?
Oh, I'm sorry, my computer muted itself. I was talking to myself. I apologize.
It's an awkward moment. Go ahead.
Yeah, sorry about that. I was saying that the foveal contour looks good, and looking at the structure of the retina, everything appears for the most part pretty good. You have on the left side of the screen, yeah, that one focal area, which I am assuming is going to correlate to one of those lesions that we saw on the colored fundus photo, sort of just above the RPE there, protruding on the cells directly above it, kind of pushing them a little bit anteriorly.
All right. And then this is the other eye.
Fair enough. So we have an OCT of the left eye. We have another, for now I'll call it deposit directly subfoveally, causing the entire neurosensory retina and overlying retina to be pushed anteriorly just above the RPE there. We also see a couple other of those similar deposits scattered along the OCT in both directions from the fovea that we saw in the right eye OCT as well.
Dr. Klein, are these?
They look like cells.
Yeah.
I don't know why they'd be there.
I was confused also.
Might have asked for it. But I don't think there's no uveitis. So yes, please ignore that.
Okay, I was confused there. I ignored it. So, all right. So this is a late FA of the right eye.
Okay, so we have a late FA of the right eye. We have both venous and arterial filling, which we would expect in a late FA. It looks like there is, I know it's just one picture, but leakage coming from the vessels all around the foveal avascular zone and kind of extending out a little bit more temporally within the macula as well.
You're right. You're right not to use the word leakage.
Yeah.
So I would just say hyperfluorescence.
Yeah.
Okay.
Because it is just one image. So your instinct was correct.
And it's deep.
And this is even later, just more spread out, but it's basically the same. So yeah, it's hyperfluorescence. It could be staining versus leakage. It's hard to tell. And then here's the left eye from the beginning now.
Okay, so we have just the beginnings of arterial filling here, and already we can sort of start to see that there is a little bit of hyperfluorescence appearing where that lesion was in the colored fundus photo, as well as a couple of the other peripheral lesions to that central lesion.
This is really tricky. There's 5 causes in the lecture of hyperfluorescence on a fluorescein. One of them, the reason that's fluorescing, can you think of why that would be fluorescing at this point? That central lesion. It's really, really tricky. This is actually autofluorescence. So there's nothing going on in that lesion. In the very first images, you'll sometimes see autofluorescence, and then what happens is as the signal goes up, that'll disappear.
Like this one.
Yeah. So this is a very early. So that's just autofluorescence initially.
Correct me if I'm wrong, but I thought that once you started getting the filling of the arterioles, the fundus autofluorescence was sort of over at that point. Was I mistaken?
It should. No, it should. But this is a really autofluorescent lesion.
Oh, okay.
So I would say 9. You're very good. I appreciate that. So yeah, I'd say 99% of the time that's probably right, or 95. But this is so autofluorescent. I think it's overriding. Well, I could be wrong, but let me see. Otherwise, it's a window defect. But I think it's just hyperautofluorescence.
Okay.
But I think that's true, Scott. You're absolutely right. Usually, because it's a signal to noise thing. So usually as soon as the fluorescent gets to the eye, the autofluorescence disappears.
Okay, so this is without the autofluorescence, and it's a little bit later.
So the autofluorescence within the central lesion that we had there is now gone. We see that the arterioles are filling. I'm not seeing any hyperautofluorescence spilling from where we would expect it at this point in time. Everything still looks okay. We do have a darkening a little bit larger than I would expect around the foveal avascular zone there.
Hypofluorescent.
Yeah, hypofluorescent, sorry.
And this is the laminar, beginning of laminar.
So now we're seeing the laminar phase. The hypoautofluorescence is beginning to increase. We see it extending inferiorly, nasally, and temporally. Again, no unexpected hyperautofluorescent defects yet.
You can use hyperfluorescence now. You can
Not
just use
auto.
fluorescence,
Yeah.
because we're out of them.
Just hypofluorescence, not
Yeah,
autofluorescence.
you can just use fluorescence.
Okay, so we're again still progressing. The hypofluorescence is becoming more prominent, spreading in every direction compared to the last phase, I believe. We are seeing some hyperfluorescence surrounding the border of the hypofluorescent lesion.
And then, well, we'll get to it in a second. So thinking of the OCT, what kind of hypofluorescence is that more than likely?
Blockage.
Good. Yeah, so this is a late photo. You just see the hypofluorescence with the surrounding hyperfluorescence. And this is a zoomed in photo, the same. And this is an ICG of the right eye.
Okay, so we're looking a little bit deeper as the ICG does. I admittedly am not the greatest at reading ICGs, but for the most part, I think it looks pretty normal. Is that correct?
Yeah, so yeah, I would say it's mostly normal. You just have these little hypofluorescent spots that are probably blocking from those lesions we were seeing on the other photos.
And the main thing I get ICGs for is looking for neovascular membrane. So typically you're like 5 to 10 minutes out, you're wondering if there's a big plaque there.
Okay.
So the early ones, early ICGs are useful for a couple things, but not much.
If you want to sound really sophisticated, you can call it hypocyanotic or hypercyanotic.
I don't like that though.
As soon as you said that it was an ICG, I was racking my brain on.
It's fun.
It sounds deadly.
It's in dark chocolate, probably.
Yeah.
But similarly here, Scott, same thing. So the vessels look okay. You just have these areas of blocking that block some of the portal vessels from above. All right, so pertinent findings, if you want to quickly summarize what you remember, and then I'll show what I had written down.
Sure, so we have in the right and left eyes a couple of lesions on the fundus photos. We have the larger plaque on the OCT subfoveally. We have hypofluorescence of the left eye on FA, and then the same finding on ICG of the left eye as well.
Yeah, and I mostly focus on the left eye, and this is what I wrote down. So decreased vision, yellow egg yolky appearance. There's that deposit of subretinal material, like you said. Hyperautofluorescence in a kind of homogeneous lesion, and then blocking on FA and ICG. So do you have a differential for us?
Yeah, I
The
was
top two
thinking
are.
that it was probably Ampy.
Anything else?
You can go broader for starters.
How old's the patient?
70.
Yeah, it's a little old for him.
Yeah.
Oh,
It's a 70.
for some reason I thought they were younger. I apologize. I thought
Sorry,
it
that's
was
okay.
female. Is it not?
It's a
an old-
70-year-old male, yeah.
Old guy. Okay.
And then as soon as we mention egg yolk,
Huh?
we'll throw in a pattern dystrophy.
Nice. And so what's always on the differential for pattern dystrophy?
Vitiliform.
Right, but you also have to make sure, it's also are concerned that it could be macular degeneration. So those are the two main ones. And this is the list that I came up with. So macular degeneration, Stargardt light disease, Best disease, although this is older patient.
Yeah.
Pattern dystrophy, other inherited maculopathies, cone dystrophy, and then CSCR, you could late, or syphilis is always on my differential.
They see so much. It's ridiculous. Scott, that was a very good job. I appreciate it.
As a board pro, whenever you think pattern, you can always throw in macular degeneration and central serous. Those three should go together on your differential. Once you hit 3 on the boards, you passed as far as creating a differential diagnosis. And then you can, if you really knew this was pattern, then you can narrow it down from there.
So the diagnosis, pattern dystrophy, or in this case, adultiliform pattern dystrophy. So pattern dystrophy is an autosomal dominant macular disease. It's broken into 5 categories. The most common is the adult vitiliform. There's also the butterfly shaped, reticular, multifocal, Stargardt stimulating, and the fundus pulverulentus, which is the most rare. And what you see is the accumulation of photoreceptor outer segments that are not digested by the RPE, and that causes that space, and like Scott mentioned, the lipofuscin. I thought it was interesting that some patients have different patterns in each eye, and some families can have different patterns even if they have the same mutation. And then even more interesting was that one pattern may turn into another in the same patient over time. So I think it sounds it's more of a spectrum rather than a specific type of pattern dystrophy.
Dr. Gass was very proud of a lecture he had where he had he had ducks, he had all these different shapes. Yeah, he had like a duck, a bird, or this, or that, elephant.
For the pattern dystrophies,
that's
funny.
what
That's funny.
Exactly. It's normally a symmetric disease, although you can see in our patient it was asymmetric, and it can be occasionally associated with systemic diseases. Myotonic dystrophy most commonly has reticular and or butterfly. Pseudoxanthoma elasticum has pulverulentus, and then maternal inherited diabetes and deafness can kind of have any of them. And something that we see on up the question on OCAPS is that the gene you want to look at for is PRPH2 or RDS for pattern dystrophy. And so treatment-wise, there's no great treatment. Sometimes, we confuse it with macular degeneration, and sometimes you think that that deposit is a new CNV, so that people get anti-VEGF or PDT, and it doesn't really help the patient. Vision loss is generally progressive and very slow, but it can develop to a macular hole, which does not improve with vitrectomy. And eventually you get geographic atrophy.
You can get secondary CNV,
You can get
but they're
second-
less common than
Correct.
wet macular
I
degeneration.
saw a patient yesterday down, we see snowbirds, and he was here for his second shot,
Yeah.
and he had pattern dystrophy. And I was
And what's
thinking, I
interesting.
wonder, I don't, he's only here for a month. People come here in January, February, and I treated him, but I was thinking, how big?
And you can get geographic atrophy looking at these when they get atrophic, but are those actually geographic atrophy is a question.
Right, I mean,
Well, show this case,
Yeah.
because this guy hasn't seen me for a while. He's here for a reason too.
okay.
Dr. Cohen, were you saying that you were treating the pattern dystrophy or the CNV associated with the pattern dystrophy?
Well, what happened to me, this patient was a follow-up from one treatment with Avastin a month ago, who's visiting Florida for a month with wet AMD, and he had a pattern dystrophy. Having not seen the initial pictures, I assumed it was wet AMD and treated him because he's only here for a month. But no, I wouldn't treat pattern dystrophy. I did once do a limited macular translocation on a pattern dystrophy patient, which didn't work. But it was an account there. If you really dig, there's an old patient in Archives of Ophthalmology where someone presented 2 or 3 successful cases of a limited translocation and where they got vision up to 20/40, but I don't know that was what that was, because for my patient, it didn't do anything. It was actually kind of cool. When I detached the retina, the yellow stuff came right up with the retina.
Really?
It was like stuck to the retina. Yeah.
So you just took it.
Yeah, just moved it to it didn't move much, only moved it. The limited translocations were interesting surgeries. I moved it like he was an accountant, you know, I felt bad, he was losing his vision. It was in the night. We did all sorts of stuff at night.
Spin the muscles with the limited.
No, it was not limited.
That's the complete ones you would.
Yeah, that was still on.
So I explained it. They used to make these scleral bypass, they used to make
Yeah.
scleral infoldings, and it was interesting. It was the treatment of choice for wet AMD for a while.
It was a cool procedure.
And it worked. The problem was it didn't change the underlying wet AMD,
Uh-huh.
right? So they would always recur. And of course, let's say you translocated it a little bit temporally, you knew that the AMD would screw you and go nasal, right?
Uh-huh.
Where you went from.
And you only got a millimeter. You didn't get
right.
much.
You got
1, 2 maybe. But for this disease, it would have worked if it was
right, because
the
you
proper
wouldn't
treatment.
have AMD behind it or wet AMD.
Right, because it wouldn't travel, yeah.
Yeah.
So, this is photos of the 5 different types. Yeah, so this is reticular,
Right.
this is the butterfly, this is the adult
Yellow,
vitelliform, this is the Stargardt-like disease, and this is the
Pulverilensis,
pulverilensis, yeah.
Thanks.
I actually had emailed Dr. Cohen to ask if this one was the butterfly, because it wasn't a perfect circle, but I see that it's different.
Yeah, those are like the wings. So the head's on the left and the 2 wings are coming out top and bottom.
Uh-huh.
But they don't continue. So you'd have to imagine the rest of the wing.
In the
Looks like a
lenses, is it depositing in the retina, or is it just that's the appearance of it? Because I know they get like
I don't
that
know.
orange.
Some of these diseases, hold on, where is it? Am I going backwards or forwards?
Other way. You're going to the photos again?
Yeah, I was gonna, hold on, sorry. Some of these diseases are very rare. So I don't know that I've ever seen that. And the difficulty with some of these things are, like, this was described by guess. And if you saw one case, you know, like juxtafoveal telangiectasia type 3 may not actually exist.
Yeah.
You know, but it's in the atlas. So this is a similar thing.
What's neat is you do the unlimited translocation and you have geographic atrophy. When you drop the new phobia, you get a new spot of geographic atrophy.
That was surprising.
Very telling.
I did a couple. Yeah. Okay, go ahead.
So back to the patient, he had a vitrectomy and a laser for RD in the good eye, the right eye by Dr. Cohen. Vision in the right eye remained good after that. The left eye became worse and it developed central geographic atrophy. And the vision, as you can see, declined every year in the left eye. And here's the OCTs.
So one of the things that a conversation I mistakenly had, you guys might have too, is sometimes when you go from on the left, the 3rd one down, where there's the big deposit under the retina, and then the patient comes for the next visit on the top right, whatever that is in 2018, you say, oh, look, you're getting better. You know, but you're not. So in general, when like drusen go away and when deposits go away, that just means the retina is kind of, the retina is not generating deposits, it's dying. And then what you find is the atrophy. And if you look at the bottom right, I mean, that's a pretty bad, that's a pretty nasty atrophy. That's where he's at now.
Yeah, 2022.
Syfovre patient or clinical trial patient.
Yes, right. Absolutely.
Yeah.
That was an excellent job. Anything else?
I think that's it, yeah.
No, you guys do one. Scott, that was excellent.
Yeah, good job.
Anybody else need to go soon? Because we can put another one in or we can sort of go haphazardly.